Good evening, everyone, and welcome to CornerStones Best of DDW in IBD 2022 for New Zealand webinar. I'm happy to introduce tonight Professor Richard Geary, who'll be bringing you our Best of DDW program.
Thank you very much, Joe, and welcome everyone to Monday night. And we're in August now, which is a month or so after DDW, but of course the research that was presented there is still very relevant to our ongoing practice today and into the future. So this is the 13th annual update of diagnosis, prognosis and management of IBD, and obviously last year lots of these were done by webinar. This year just the one at the end for those who couldn't make it to one of the in-person meetings or were not close to one of those going on. So just to remind you, firstly, I want to give my thanks to Janssen for their ongoing support of this initiative. Best of DDW, I think, is one of the best things I've been involved with professionally, and certainly from an academic point of view. Really, at the end of this session, I hope that you'll really understand the key outcomes from DDW with regards to IBD, and most importantly, things that will change your practice. So this is stuff that's clinically relevant that we'll be presenting to you tonight. And it's really great that Janssen can support this through an educational grant, and obviously it's unrestricted. They have no say in the content of what we present. Because of that, though, the opinions that we present today will include things that include off-label use, etc. So you need to clearly take all these things and integrate them with your own clinical knowledge. For those of you who don't know how Best of DDW comes about, what we do is we meet before DDW and go through all of the abstracts that are submitted to DDW and work out the ones we think that have been most clinically relevant. During DDW, those who could go went along to the talks, the posters, and then further narrowed down the presentations and to what they thought would be best. And then following this, there was a plenary meeting in-person meeting where there was voting on which slides would be selected, and then the final slide sets put together. Now, the final slide set is large. It's over 100 slides, and it wouldn't really fit into the format that we run here in New Zealand and in Australia. In New Zealand and Australia, we're much keener on having interaction and discussing slides that are relevant and topics that are relevant. So therefore, we've further reduced the number of slides down to make it fit into the time frame that we have. However, the download that's available on the GoToWebinar platform that you have there includes all of the slides and in PDF form and all of the abstracts. So if you feel as though you're missing out tonight, there is more information available for you there. Here's evidence that DDW really did happen this year for those of you who couldn't make it. I happened to be in group 1, so you can see an empty chair there. That's where I would have been sitting at the kickoff meeting, and then the content development meeting below there. And a wide range of fellows who helped this year, including Akhilesh Swaminathan, who was the fellow again this year. He's been lucky enough to be fellow 2 years in a row, but it's yet to go to DDW because both times it's been done remotely. The faculty, similar names to those that you've seen previously, and the fellows, again, similar names to those that you would have seen previously for Akhilesh as well. So these are the different topics that we'll be covering tonight, and I'll go through these. And as I say, as we go through, we'll stop from time to time and go through the questions in the chat. So we'll start off with the epidemiology, natural history, and prevention of IBD. So this is a large combination slide that shows you epidemiological data from studies presented at DDW, but from all around the world. So starting at the left-hand top and going around, firstly we can see from a large US claims database that they believe the prevalence of IBD in the US is approaching 1% now. So that's 1% of the population, a large number of patients. And of course, if we extrapolate that to many other parts of the world with high populations, that's a lot of people potentially, if the numbers were the same elsewhere, and likely they may not be, but certainly large numbers of patients. Interestingly, the rate of IBD new diagnoses from around the world appears to have plateaued in some parts of the world. So there we can see data from the Mayo Clinic, from Olmsted County, where the rates of new diagnoses of Crohn's disease and ulcerative colitis have gone up slightly for, or plateaued, if you like, for both Crohn's disease and ulcerative colitis, or maybe even dropped. On the other hand, data from Denmark, again, very good data from Denmark, which is population-based registries, showing a doubling of rates of IBD between 95 and 2018 for Crohn's disease, and about a 50% increase for ulcerative colitis as well. So significant increases in some parts of the world. Number 4, there you can see data from South India. So there they look back over 16 or 15,500 colonoscopies and showed that of all those people who had colonoscopies, IBD was diagnosed at 6.4%, which to me is a slightly worrying number if we consider the number of colonoscopies that are likely to be done in India, suggesting that IBD probably is increasing in that continent, which is worrying given the background population. Waikato has featured in DDW, Best of DDW this year. So here's Sam Selleck's study from Waikato showing increased prevalence of IBD in the Waikato region. But more importantly, they and also the group from Rotorua have now shown increasing prevalence and incidence of IBD in Maori. And while that doesn't approach the rates in non-Maori, it still shows that the rates are increasing and therefore it's likely to be a disease that continues or starts to affect that population more so than it has in the past. And finally, in yellow, data from Hungary showing increasing rates of prevalence as well all around the world. So to me, the take-home messages are that the rates appear to be going up still, but in areas where the rates are high, there may be some plateauing occurring, but we're still going to see more IBD in the future at this stage. So why do people get IBD? Well, here again is a combination slide with a range of studies from around the world looking at potential risk factors and protective factors associated with the development of inflammatory bowel disease. So these aren't causative, they're associations, but of course they allow us to generate hypotheses and understand what might be going on. So the first of these in the top there, we can see abuse as a child, so suggesting that moderate to severe child abuse was associated with an increased risk of developing Crohn's disease. Antibiotic exposure, and this was interesting because they looked at antibiotic exposure in older onset IBD. So in the 2 years before diagnosis, associated with increased use of older onset IBD, suggesting that antibiotics, just regardless of the age of use, may still be associated with an increased risk of IBD, and that was trying to control for confounders such as potential Crohn's disease being the cause for use of antibiotics. This data on mebendazole is fascinating. So mebendazole obviously used to treat worms, and what they found in this large population-based study from Denmark was that if you were treated with mebendazole before the age of 5, you're more likely to get ulcerative colitis as an adult. So suggesting there that there's also a timing issue might be important if this association is in fact true. Data on asthma and allergic rhinitis, again suggesting that the relative risk of asthma and allergic rhinitis was greater in those prior to IBD diagnosis, and we showed similar data in a case control study from Christchurch a couple of decades ago now. And EBV is another risk factor, certainly enriched in patients prior to the diagnosis in 3 independent cohorts. And that's interesting because there are other studies that suggest reduced EBV as well, but these were looked at in different ways and certainly suggesting that EBV infection may increase the risk of subsequent Crohn's disease. So those are factors that were associated with an increased risk of developing inflammatory bowel disease. What about protective factors? So both of these studies in the blue, presentations in the blue, come from the GEM study. So the GEM study is the Gene Environment Microbiome Study. And this is a study where patients, relatives, first-degree relatives of patients with Crohn's disease are recruited. And they're recruited when they're well and don't have disease, but because they're a first-degree relative, they have an increased risk of subsequently developing Crohn's disease. They've been prospectively watched, and at the moment they're looking at some of the data as these people are subsequently diagnosed. And the first thing that they found, one of the first things, was that living with a dog appeared to be protective against the development of Crohn's disease at an early age in life, with a reduced hazards ratio as shown there. And again, being in a large family also appeared to be protective if you're in a large family in the first year of life compared to if you're in a smaller sized family. Again, suggesting that these hygiene-related factors might be playing a role. So again, interesting data. Remember, these are associations only rather than anything else, but important nonetheless to see what could be going on. So no questions as yet, so we'll keep on rolling through, and we can come back to questions from this if you've been so enthralled and haven't had time to type them in yet. So I'm going to move on now to some therapies, and a range of therapies will be presented tonight, and I'll go through each one, reminding of the mechanisms of action as we go through them. So tofacitinib is a Janus kinase inhibitor, and it's been around for a while now. It works by blocking transduction of signals from janus kinase essentially receptors, and stops transcription through into the nucleus. These drugs have been around for a while, and there's always been a concern, particularly in the rheumatoid arthritis literature, that the use of these drugs may be associated with venous thromboembolism. And in fact, there's a black box warning on this drug due to the increased risk of VTE in patients prescribed tofacitinib. Now, obviously, in patients with inflammatory bowel disease, there's already an increased risk of venous thromboembolism, and there's never really been any comparative data to compare whether tofa might be associated with a significantly increased risk of VTE compared to another drug, such as an anti-TNF-alpha drug. So this was a retrospective cohort study from a large US claims database that was looking at patients prescribed tofacitinib for IBD compared to those prescribed an anti-TNF-alpha drug. And although the number of people who had these endpoints of venous thromboembolism or cardiovascular events was low, no significant signal was seen to suggest that tofacitinib was associated with an increased risk of venous thromboembolism compared to IBD patients prescribed anti-TNF-alpha drugs. So I think that these are interesting data. We obviously don't have tofacitinib, but it's an oral small molecule and one that potentially we could get in the future. I think that the key takeaway for me is, firstly, remember the risk of venous thromboembolism in our IBD patients, particularly those who are admitted to hospital having surgery or with severe disease. And then if we do get access to this drug, again, just remembering to watch out for this as a potential complication. Okay, so overseas where there is slightly wider access to drugs, it's now a question often of which drug do you use first, which drug do you use if another one fails. So this is a study that tried to address one of those questions, which was if you've got a patient with ulcerative colitis and they fail more than one biologic, which do you use next? Do you use tofacitinib, this janus kinase inhibitor, or do you use vedolizumab, an anti-integrin, which is obviously gut specific, so therefore it's got some attraction to the use of that. So this was a multi-center retrospective study with patients with ulcerative colitis with prior failure of biologics, including one anti-TNF agent who was subsequently started on vedol or tofa. And obviously this wasn't randomized, so there was propensity matching down to try and adjust for confounders. And they're looking at corticosteroid-free remission. If you look at the graph on the right, you'll see there that really there was no difference in the cortico-free clinical remission at week 16 between these two drugs. However, if you drill down a bit deeper, you can see significant differences with regards to those who were prescribed, who'd had more than 3 biologics. So if you'd had lots of biologic drugs, you're much more likely to respond to tofacitinib than vedolizumab. And if you had primary failure to a biologic as opposed to secondary failure, again, you're much more likely to respond to tofacitinib than vedolizumab. You might ask why that is, and I don't think this study answers that question, but what I think about is that tofacitinib is a small molecule, vedolizumab is another biologic drug. So patients have already failed one biologic drug, maybe they're more likely to fail another due to immunogenicity or other reasons, even though it's different classes of drug. So I think in areas where you can have more than one drug, if patients failing a biologic, in this situation, there might be reasons to make you choose one of these drugs over another. Okay, so another small molecule is upadacitinib, and upadacitinib is again a janus kinase inhibitor, and is actually available in New Zealand for some rheumatological indications. So once again, the rheumatologists get the drug before we do, but hopefully we can put more pressure on Pharmac to get better access to some other drugs. So this drug is around. It's now available in Australia for ulcerative colitis as well. And the reason we're showing this data is, again, it's a small molecule. And what this study shows is that if you put patients into a study and you give them upadacitinib and you try and get them into remission by week 8, at week 8, usually the dose is then reduced to a maintenance dose. And what this is suggesting is that maybe you can continue to give a higher dose of upadacitinib and give it a prolonged, if you like, induction therapy duration, and that will bring a lot of people into clinical response or remission over and above those who initially went into remission in the first 8 weeks. So a prolonged induction can sometimes be helpful with a small molecule. So again, it's showing that these drugs can be used in different ways. And what's interesting to me now with these new small molecules is that the old small molecules that we used were the azathioprines, the methotrexate, if you like, and those small molecules had their characteristics around them. But to me, some of the new small molecules, such as the Nibs, so that they're the Janus kinase inhibitors, the Nibs. I'm going to show you the mods soon, which are the sphingosine phosphate 1 receptor agonists. They may be different to the MABs as well. So we'll just go through these Nibs, MOBs, and MABs slowly tonight. So here's some more data on epidicitinib. Again, this is a Janus kinase inhibitor available in New Zealand for rheumatological indications, but not for inflammatory bowel disease. And what they're showing here is the speed at which these drugs can lead to induction of clinical response and even degree of remission in some patients. So we can see here a phase 3 double-blind placebo-controlled trial. This is one of the main registration trials, and what they're doing here is firstly showing the co-primary endpoints at week 12, which show that certainly compared to placebo, clinical remission and endoscopic response in these biologic refractory Crohn's disease patients was significantly greater in treatment than placebo. But what you can see here is that actually at week 2, there's already a significant improvement in what's going on. And what this is showing to me is that this isn't like the old small molecules of azathioprine that take many weeks or months to work. Some of these new small molecules work very, very fast, which means that maybe that can change the way we use them in the future with regards to whether we need to use steroids or other drugs that work more quickly in that way. So again, we don't have access to this drug, but it's exciting that a small molecule can work as quickly as this one. All right, so filgotinib, another Nib. So this is again a Janus kinase inhibitor. It's been around for a while. And again, what they're showing here is that if you start and stop these small molecules, you don't tend to get the same issues as you get with starting and stopping monoclonal antibodies or biologic drugs. And we know that starting and stopping biologic drugs, particularly if you don't have an immunomodulator on board, can be a real problem, because in those situations, patients can get immunogenicity and lose response, and then you lose that drug and you can no longer go back. Well, this is again post-hoc analysis of data from a major registration study, the Selections program, looking at patients who had induction induced with filgotinib, but then were randomized to placebo for the maintenance phase to see whether you could then re-induce these patients. So if you look at figure 1 here, the patient started off with active disease, they had induction induced, and then at week 12, some of these patients were given placebo, they got sick again, but if they got reinduction, as you can see here, they were able to get back into remission overall eventually in the same way. And that may not necessarily always be the case with a biological drug. So again, it's showing a difference with the way that these drugs can work, which I think means that there might be a special place for these small molecules as opposed to some of the other drugs that we already have access to. Excellent. Okay, so moving on. All right, so I've spoken about the Nibs, and we know about the MABs already, but I'm now going to talk about the MODs. So this is ozanimod, and ozanimod is a sphingosine 1 receptor agonist. So they work in a slightly different way. So what these drugs do is they block lymphocyte trafficking away from lymph nodes. So obviously lymphocytes are really, really important to drive that inflammatory response in the gut. And if you can keep them away from the gut by sequestering them in lymph nodes, then all of a sudden you may find that inflammation reduces. And that was what was found in the True North study, which has been published previously. And this drug is now available in a number of parts of the world for ulcerative colitis. And here we can see that if, again, you stop ozanimod and then you restart it, a significant proportion, over half of patients who relapsed, were able to be recaptured in symptomatic clinical response after reinitiation. So again, showing that with these small molecules, you can recapture response in a good proportion of patients. Okay, so here's another mod. So this is, again, it is a bit like torture me showing these drugs, but it is important because we need to know what's available, what could be coming, and also we need to be able to argue pharmac the sorts of drugs that we might be wanting. So here's another MOD, another sphingosine 1-phosphate receptor modulator. And what's happening with this drug is these studies is they're presenting data from both the induction study, which is Elevate 12, which is the 12-week induction you can see down here on the figure. And here we've got also the maintenance 12-week induction, then treat through 40-week maintenance of remission study for etrasimod as well, looking at patients with moderate to severe ulcerative colitis with standard clinical remission at week 12, week 52, endoscopy and other endpoints subsequently. And then there's open label as well, which you might imagine. So these patients had moderate to severe ulcerative colitis and they're given 2 milligrams daily. So here are the data. So the primary endpoint of the Elevate UC12 study, you can see here compared to placebo, clinical remission at 12 weeks in a quarter of patients, endoscopic improvement in 30% of patients, and then symptomatic remission at almost a half of patients. So this was compared to placebo, was effective at inducing remission at week 12. If we then look out to maintenance remission at week 52, we can see that about a third of patients are getting clinical remission. If we look at endoscopic improvement, is up to sort of over a third, symptomatic remission up towards a half, and again, significant improvements in mucosal healing as well. So again, another drug from a different category, another mechanism of action showing efficacy, and these data were first presented at DDW this year. So this drug is likely to become available in other parts of the world. All right, I might just stop there briefly if there are any questions in the chat. I can't see much there so far. If you do have questions, please put them in the chat, and I'm going to stop intermittently along the way to look at them. So I can't see anything there at the moment. That's fine. Everyone's shy, but do get tapping away if you've got things you want to say about those drugs. I know we don't have them yet, but it's good to know that they're coming. All right, so I'll move on now to some other therapies, and this is dietary therapy. So this is a little bit cheaper than some of these drugs, and Pharmac can't stop us feeding patients, so that's always a bonus. So this is real-world experience of the Crohn's disease exclusion diet that you can see here. Oh, okay, sorry, I've just been told that people can't see the chat box and that you should use the question box instead, so my apologies for that. So I'm going to go back now, and I can see a couple of questions there now. So the first question is by Guy Vautier. If you had your choice of which of these new small molecules, which one would you start with? That's a great question, Guy. Really appreciate that. So essentially, I think it's hard to know. I suppose the one I'd start with was the one I would have available. I do like, I think we've got more experience with the NIBs at the moment. So the Janus kinase inhibitors, I think that as a class, they've been around for longer in IBD. So I think we know a little bit more about them than we would with the mods. Tofacitinib, again, a bit less selective than some of the others. I do like the sound of ipatacitinib, and certainly the safety data I think are pretty good from that as well. So I think maybe that would be where I would look at. But again, I'm not Pharmac, and I'm not going to have my choice at the moment. Alison Ross has asked, are the small molecules able to be given orally? Yes, these are all oral treatments. So these are all drugs that be given orally. So again, thinking about the convenience for the patient, the reduction in costs for the patient is for the whole healthcare system for infusions and even injections is greater. So as far as ease for patients, yes, potentially useful as well. But I think the other thing about these small molecules is that they can be used intermittently. So potentially you could use them for a while, you could stop them, whereas we do worry more so about that, particularly with the anti-TNF-alpha drugs. So just reminding you, if you can use the questions rather than the chat, as we said at the start, that'll be great. All right, so moving back now to food. So the Crohn's disease exclusion diet. So this is data from the centre that invented the diet, the diet, and it also was involved in the randomized control studies. Now they're just looking back on their real world use to see certainly what's the real world utilization like, and what sort of efficacy is there. So this is a single centre retrospective study of patients with Crohn's disease commenced on the Crohn's disease exclusion diet. This is a whole food diet which is designed to target the gut microbiome and intestinal immunity. And as I say, randomized controlled trials do show efficacy. So what they did in this is this looked back at all their patients, and they looked at clinical improvement, the difference between baseline and follow-up in the Harvey-Bradshaw Index at week 12. And they looked at patients who had a Harvey-Bradshaw Index of less than 5 at week 12 to determine who was in clinical remission. So 96 patients looked at, 72 had active disease. This was the sole therapy in 42%. And then there's a 50-50 split, and some were used as a bridge to a biologic or an adjuvant therapy. Overall, adherence was pretty good. Over half were highly adherent, 20% partially adherent. And at week 12, 62% were in clinical remission, accepting that some of these patients were on a biologic or had other things going on, or was an adjuvant therapy. But certainly there is some useful changes there. We can see reductions in disease activity there from baseline to week 12 as measured by the Harvey-Bradshaw Index, and also significant reductions in fecal calprotectin. And that's important because often dietary therapies may be associated with a placebo effect or have an effect on bowel irritability rather than bowel inflammation. So to show a reduction in calprotectin is really quite useful, but of course it's a mixed cohort. And again, suggestions here that adherence was a major driver of improvement, but of course it might be that improvement was a driver of adherence as well, so hard to be sure about that. So I'm not sure whether you have access to this diet around New Zealand. We certainly have dietitians who are able to use this diet, and certainly we've often used it as a way of coming off exclusive enteral nutrition. So people might go into partial enteral nutrition and may have Crohn's disease exclusion diet is their diet that they have at the same time. So that can be quite helpful for some patients. Good. All right. So moving on now to another food or diet related study. So this study is from St Thomas's, Peter Irving's group there. What they did here, what they did at St Thomas's is they're very strong believers that exclusive enteral nutrition used before an ileocolic resection for patients with Crohn's disease leads to better outcomes, both with regards to reduction in complications, but also potentially downstaging disease. So they believe this already. So what they did is they went back and looked at all the patients who had had an ileocolic resection, and they split them into those who had had more than 2 weeks of exclusive enteral nutrition versus those who had had no nutritional optimization over that period of time. So this isn't a randomized study. These are just basically looking back historically at patients who did one or the other. So clearly there could be some confounders at play here. And in fact, when you look at the baseline characteristics, the patients who had exclusive enteral nutrition before surgery were much more likely to be on a biologic and much more likely to receive antibiotics, which could impact some of these post-op complications that are shown below. So they had 300 procedures, so large numbers of patients. And what they showed overall was that, in fact, if you were in the exclusive enteral nutrition cohort, you had a significant reduction in overall surgical, non-surgical, and infective post-op complications within 30 days, suggesting that this is potentially something that could help patients and reduce complications. Of course, these are patients who are able to wait. There are some patients who have emergency surgery or need surgery because they're so unwell, but this isn't those patients who maybe having a slightly delayed operation may enable them to be optimized prior to that. And certainly this is becoming something that we're offering more often now in Christchurch, and Catherine Wall, one of the dietitians here who's done a lot of research in exclusive enteral nutrition, has done a feasibility study looking at using this, and certainly we're finding that probably 60% of patients are able to do this. All right, so we'll keep on going. Again, any questions, put them in the question section, and we'll move on from there. Okay, so this is, I think, one of the most important studies from DDW this year. So if you've been snoozing or eating your nice roast dinner while I chat away, please stop briefly to listen to this study, because I think that it does have a lot of implications for the way we manage IBD here in New Zealand. So this is the SPARE study from Edouard Louis from Belgium. And what it's looking at is what you do, which drug do you stop if you're going to stop a drug for patients who are on combination therapy who have Crohn's disease. So it's a really important question, because we're often asked this question, and often we're trying to work out what should we do, what should we stop. So it's a prospective study, and patients who had Crohn's disease who are on combo therapy, they've been on combo therapy for at least 8 months, and they've been in a long sustained steroid-free remission for at least 6 months, were randomized to one of 3 arms. So in red, they had continuing combination therapy. In green, they had stopping infliximab but continuing the anti-metabolite, and in C, stopping the anti-metabolite but continuing with infliximab. And then they watched what happened over a 2-year period. And I like that because, you know, at the end of the day, Crohn's isn't about what happens the next day or week or month. It's about what happens in the long term and how we can keep these patients well for a long period of time. So what you can see from the Kaplan-Meier curve here, that those who are on combination therapy in red carried on much the same with a very small number of patients having relapse. Those who continued with their infliximab but stopped their anti-metabolite pretty much had the same story. They had the same outcomes as those who were continuing with combination therapy. Those who stopped their infliximab but continued with their anti-metabolite, what you can see there is many of those relapsed, but still out to 2 years, over half of patients were in remission and didn't have relapse over that time. Now, if you look below here, what you can see is that despite the fact that there was a difference between those who stopped their infliximab and those who continued with combination therapy or stopped their anti-metabolite, the total time spent in remission was pretty much the same. And the reason for that was, if you look over here, of the people who relapsed, many of those were retreated, and of the 23 people who relapsed, who were retreated in the stopping infliximab arm, most of those were able to get remission back again. So even though many of these people relapsed, they were able to go back into remission subsequently. Again, generally pretty safe, a bit of severe infection in a couple in one group, but overall quite safe. So to me, this is a really important study because I think I could show this to a patient and say, look, right now this is where you are. I know that you're in sustained steroid-free remission for a long period of time. I'm feeling as though we could talk about this. If we stop one of these drugs, the one to stop may well be the anti-metabolite, because the story might be the same. But if we do stop the infliximab because that's what you want to do, that's fine. But there's a reasonably good chance that we can recapture you into remission if we need to. So again, this study to me is really relevant to New Zealand clinical practice. So I think this is a question that we're answered a lot, and I think this study answers that question. So again, I think a really interesting and useful study from DDW this year. So again, I'll keep on talking here, but if you have any questions or want to go back and discuss this, let me know. And remember, this slide will be in the handout that's available to be downloaded and will be sent out tomorrow as well. So again, a really useful graph, I think. So this is the REM switch study. So in some parts of the world, infliximab isn't just available intravenously, but it's also available subcutaneously. And in this study, what they wanted to do was to determine, could they switch people from IV infliximab to subcutaneous infliximab without too much trouble. So they took patients who were on intravenous infliximab, stable in remission, and what they did is they looked at defined relapse as a partial Mayo score greater than 2, Harvey-Bradshaw greater than 4, or an increase in fecal calprotectin versus baseline. Looking at the patients who went into the study, this is a typical group of patients anywhere around the world on infliximab. So under half of them will be on standard dosing. Under half will be on 5 milligrams per kilogram 8 weekly. But significantly greater numbers are on 10 milligrams per kilogram 8 weekly, or even 10 milligrams per kilogram 6 or 4 weekly, as you can see here. So what they did here is they put people into the study, they switched them to 120 milligrams to subcut every 2 weeks, and then they measured these things over each visit. And what they found, not surprisingly, was the greater the dose of infliximab that you were requiring intravenously, the higher the rate of relapse and the greater the risk or the greater the need for increasing the dose of subcutaneous infliximab to 240 milligrams 2 weekly instead of 120 milligrams 2 weekly. And that's sort of what you'd imagine. And what it's saying is if you need more drug intravenously, then you're likely to need more drug subcutaneously. So again, if we've got access to subcutaneous infliximab, we want to make sure that the doses that we were giving patients subcutaneously reflected that which they were getting intravenously, or else there's quite a high rate of relapse, as you can see, particularly in the red group there who are having 10 milligrams per kilogram 4 weekly. Okay. All right. So we're going to talk a bit about vedolizumab now. So vedolizumab is a anti-integrin, so it stops white cells migrating out of blood vessels into the gut. So it's a bit like the mods I showed you earlier, but this time instead of the white cells moving out of the lymph nodes, it's stopping them moving out of the blood vessels. So this drug's been around for a while overseas. And of course, the particular interest in it because you're only really causing immunosuppression in the gut, which might be helpful for patients who have got malignancy elsewhere or high risk of infection. So in this study, they're trying to work out, can you dose optimize vedolizumab? And if you do that, can you get higher rates of mucosal healing? So they took patients who were not responding to vedolizumab in ulcerative colitis, who had determined by their partial Mayo score. At that time, they then randomized people 1-to-1 to either standard vedolizumab dosing or dose intensification based on concentrations of vedolizumab, and then they watched them out for a reasonable period of time anyway, out to where are we? To week 26 to see whether there was mucosal healing. And what they found was that even if you dose optimize, you don't get any higher rates of mucosal healing with dose optimization compared to standard vedolizumab dosing. So no significant difference there. All right. So vedolizumab also potentially could have a role to play in pouchitis, and certainly talking to colleagues overseas, this is something which I think could be particularly useful, but there hasn't been a lot of randomized data to support that. So this is a randomized control trial in patients with pouchitis after IPAA for ulcerative colitis. And usually we use antibiotics in these patients, but even chronic antibiotic refractory pouchitis is quite an issue. So these are patients who had chronic pouchitis and they were randomized to either placebo or vedolizumab. And at week 14, what you can see here is a statistically greater rate of remission for these patients compared to placebo, and that's sustained out to week 34 as well, and that's backed up by pouch disease activity rates and other changes as well. So certainly a safety profile was consistent, and it was consistent benefit across clinical, endoscopic and histological endpoints, again suggesting that this drug could be a really useful drug in this indication. All right, so another MAB now. So we've done the NIBs, the MODs, and now we're into the MABs. So this is ustekinumab, also known as Stellara. So thanks to Janssen, we're very lucky to have access for a number of our patients through their compassionate access program, early access program, sorry, to this drug. One of the questions that's often raised with ustekinumab is that there has never really been a dedicated ustekinumab Crohn's disease fistulizing disease study done. So what they did in this study is they went back to their phase 2-3 studies, particularly Seaview, which is on the left, and Stardust on the right, and wanted to look at, in those patients who happen to have perianal fistulas going into the studies, what proportion of those patients had fistula closure at the end of a year. So the Seaview study was comparing adalimumab to ustekinumab for other outcomes, but here we can see the data for fistula healing. We can see here that the rate's about 50% compared to about 30%, 37% for adalimumab. And for Stardust, again, we can see here about a rate of 50%. Now, I will point out that the numbers in these studies are small, but they are data to suggest that consistently there appears to be about a 50% fistula closure rate across these studies. And I think these data are useful because right now we're very much TNF-alpha infliximab in particular driven for our patients with Crohn's disease and fistulas. But this is suggesting that there may still be some efficacy in the ustekinumab group. And we didn't have any data here on whether these were patients who had failed TNF-alpha drugs or not. But I think nonetheless it does offer us some hope that if we are able to get this drug funded through Pharmac, that it will give us some efficacy in those patients with perianal disease or fistulas as well. All right, so another IL-23 drug here, mirikizumab. So again, this is another sort of registration trial. It's a big deal trial from DDW. What we can see here, phase 3 study of patients with ulcerative colitis. This is Lucent 1, looking at induction of remission. And what we can see here is at week 12, in these patients on this intravenous drug given 4 weekly, that patients went into remission significantly more likely than placebo. Rates still not enormous, but certainly remission nonetheless, and that there was an improvement that was probably better as seen here in biologic naive compared to biologic failed, with those significant safety signals seen there. Here is Lucent 2, which is the patients who did respond to the induction therapy were then randomized to maintenance therapy in a blinded fashion, as you can see there, using this IL-23 drug. What you can see here is of those patients who responded out to 1 year, about a half of them had ongoing clinical remission. And if you look at endoscopic and histological endpoints, they were mirrored out to week 52 as well, suggesting again another drug we have here, another IL-23 drug that's showing efficacy in moderate to severe ulcerative colitis. Okay, so another IL-23 drug, so Kazumab, some of you may be aware of this drug. It's being used in clinical trials in New Zealand at the moment. There's some fantastic Galaxy studies around at the moment which compare Kazumab with placebo and with ustekinumab, so an active comparator study. So again, hats off to Janssen for putting one of their own drugs in these studies to compare. Now this is Galaxy 1, which is the phase 2 study. The phase 3 studies getting very close to closing now around New Zealand. These are the phase 2 data, and what you can see here is Kazumab for moderate to severe Crohn's disease, 3 different doses of Kazumab compared to ustekinumab, and what you can see here is that rates that were at least as good as ustekinumab for clinical remission out to week 48. And again, adverse events very minimal there, and certainly consistent with the known safety profile and other indications. So I'm excited about this drug. I think this IL-23 is a great target and something that we need to be able to prescribe if we can. Obviously, we're limited at the moment with what we can get. Now, another IL-23 drug, which I think will be becoming available in other parts of the world soon, is Kazumab. Again, another IL-23 P40 unit specific blocker. And here what they're doing is they're looking across studies to look at outcomes in bio-naive and biologic failure patients, showing that across those endpoints that certainly induction remission rates for endoscopic endpoints were higher regardless of biofailure status. So good endoscopic response and remission, as you can see there, ulcer-free endoscopy, really hard endpoints that are showing efficacy. And again, clinical and endoscopic endpoints there, again, good in Crohn's disease, but showing some benefit in those with any chronic involvement in particular, suggesting that this drug may be slightly better in that group of patients. So again, interesting data. All right, there's a few questions rolled in, so I might just stop here. I'm going to start with Judith, who's asked, do you think that the infliximab withdrawal study, that's the SPARE study I showed earlier, can be extrapolated to adalimumab withdrawal? So I'll go back to the study just so that we can remind ourselves what it showed. So these are the data here. So obviously we don't have an adalimumab arm here, but certainly we tend to use a similar combination therapy preference for adalimumab, but maybe slightly less, given that adalimumab is humanized and maybe isn't quite as at risk of immunogenicity as infliximab. However, the data for combination therapy with adalimumab are still way better than they are for monotherapy. So it probably still would be our preference to use it as a combination agent if we can. Can we extrapolate it to this? Well, I think we don't have the study. Will we ever have the study? Probably not. I think it's reasonable to extrapolate it, but as with any extrapolation, you'd have to explain that to the patient if you're showing them the data. But I think the key thing here to me is making sure if you are going to stop a biologic that you must continue with the anti-metabolite. And that's a really important message to the patient, because they might be well, they might go away, they might say, oh, I feel great, I'll stop that. And then all of a sudden you've got a high risk of not getting re-inducing patients, I think, at that point in time. So I think yes, but I think the message is making sure patients remain on those other drugs. Guy has asked the same question, so that's not there. I really sent to the New Zealand using subcut infliximab. This is from Kyle Hendry. And are there barriers from Pharmac due to its alternate route? So at the moment, infliximab is marketed by Janssen, is only available intravenously. So it's not formulated to be given subcutaneously. And I'm not sure that Janssen have a subcutaneous infliximab available, but there are other pharmaceutical companies who do have subcutaneous infliximab. We just don't have access to it yet in New Zealand. And again from Ali Jaffa, any mention of infliximab drug level before switching to the subcutaneous route? Again, remembering we don't have that option in New Zealand with regards to switching at the moment for subcutaneous. But in that study, that was the one that's the REM switch study, which we just flipped past here. I think that they did measure that, but they didn't report on it specifically here. They did measure anti-drug antibodies, etc., along the way, but again, they haven't really reported on that. So it would be interesting to know whether drug levels could help in that regard. But I think the key thing for me is if we ever get access, just work out what you give intravenously and allow for that subcutaneously, which is, I don't think, rocket science. Cool. All right, I'll flip back down to where we were. All right, so I've been giving you a lot of torture to date by talking to you about drugs which we don't have access to, but now I'm just going to ramp that torture up, just ratchet it up just another level, if you like, by saying, well, why don't we combine lots of drugs we don't have access to and see if they're any better. So these are data from a study which is a randomized control study which compares combination therapy with gozalkamab and golimumab together versus golimumab monotherapy and gozalkamab monotherapy. So golimumab is a subcutaneous anti-TNF alpha drug, and we know it works for ulcerative colitis. We don't have it in New Zealand, but it does work. So in this study, essentially what they've done is compared golimumab versus gozalkamab in combo therapy. And then afterwards, they then go into a monotherapy phase, which you can see there. So golimumab continues, the combination therapy and gozalkamab continue on gozalkamab. So looking at the data, week 12, what do we see? Well, there is a significant benefit between golimumab and combination therapy, but not monotherapy with gozalkamab. Look at Mayo score here, though, looking at individual subscores, etc., we can see a significant benefit of combination therapy over monotherapy at week 12, and modified Mayo again at week 12 we can see a significant benefit of combination over any of those by themselves. So it would appear that combination therapy is giving more efficacy. What's the cost of that? Well, again, the numbers aren't huge here, but it does appear to be a few more infections here, not much else here in this area, but certainly 1 or 2 more infections, influenza, sepsis, etc. So certainly something to be aware of. So again, to me, what's interesting is, can you start to induce people into remission using combination biologic therapy and avoid steroids? Because again, steroids have a lot of risks associated with them. Well, again, these are the sorts of questions that are being asked now, and I think are very interesting to see how that will pan out. So if you thought that study was fun, well, look at this one. This is Explorer, and this is pretty wild. So this is triple combination therapy with vedolizumab, adalimumab, and methotrexate in patients with high-risk Crohn's disease. So it's an open-label study, so no randomization going on. Phase 4 study, triple combination. These are patients who are quite sick, so they've got lots of markers of high risk of progressing to complicated disease. So they've got the CD-PAT test. These are patients who are at the end, are likely to do badly. So the risk is higher of them doing badly, so therefore the reward is potentially higher as well. Although the risk is also higher if these drugs all combine to cause trouble. So what they've done here is they're giving vedolizumab for induction, but what you may or may not know about vedolizumab is it's a great drug in that it's gut-specific immunosuppression, so no immunosuppression elsewhere in the body, but it doesn't work that fast. So it's sort of got a rather slowish onset of action. So it can take out 8, 12 weeks or so before it's really underway. So what they do at the start is they amplify that induction phase by giving adalimumab at the same time, and then to sort of help the adalimumab along, they give methotrexate as well. So adalimumab, methotrexate at the start to get you well, vedolizumab coming in behind to keep you well out to week 102. So all 3 at the start for induction, and then week out to week 102, they're aiming to give the vedolizumab. Now, they're only reporting data out to week 26, which is when the adalimumab was stopped. And what they're seeing there is high rates of endoscopic remission at week 26, a third in endoscopic remission. These were sick patients, and 50% in clinical remission at week 26. Again, that's pretty impressive data. These are new patients, so they're bio-naive, and they've got early disease, but they are at the more severe end of the spectrum. So I think this is a really fascinating study, not so much for the specific results, but the way that now we're starting to use drugs in a way that fit with their mechanism of action, their safety profiles, and how they might fit together. Now, of course, cost is no issue in this sort of situation, but over time we might start to use these drugs in different ways that give us more information. And these drugs are more helpful now than these single drugs versus placebo studies. We need comparative studies and combination studies, in my opinion. So interesting stuff. All right, we'll move on. So disease activity and monitoring. All right, so here we've got a prospective study using infliximab TDM during maintenance to look at disease control. It's the NORDRUM study. This is a big study from DDW. The first thing I'd say about the study is that there's a range of patients in the study, 454 patients in the study, but they're from a range of indications, including rheumatological, dermatological, and also gastroenterological. So patients were in it's an investigator-initiated randomized study comparing proactive TDM versus standard dosing. So by proactive TDM, what I mean is that patients have drug levels monitored and measured, and then the dose is modified based on that drug level, regardless of whether the patient is well or not. So this is trying to get the dose of drug right, get the drug concentration in the therapeutic range and maintain it there to try and prevent recurrence. And that's as opposed to reactive monitoring, where someone is sick and then you measure the level and then you change the dose based on this. This is a proactive model, if you like. So what they did is if you were in the therapeutic range, and the therapeutic range was 3 to 8, so maybe slightly lower than what we would aim for, but 3 to 8. If you were slightly low, you'd just think about it. If you were very low, you'd definitely increase the dose, or if you had antibodies, you would switch therapy. On the other hand, if it was high, you'd think about increasing it or decreasing it. If it was very high, you'd definitely decrease it, as you can see here. And this is what they did. So increase the dose. That's what they did, up to 10 milligrams per kilogram by increasing the dose slowly, or decrease the dose interval. And here's decrease the dose, what they did here. So they looked at sustained disease control without disease worsening over 52 weeks. And if you combine the whole group together, then if you had TDM, you did better than if you had standard therapy across all indications. Now, if you then break that down into the different subgroups, if we look now, the UC group was 16% of the TDM group and 18% of the standard group, and the Crohn's group were similar proportions of the TDM groups and standard groups here. And if you look overall, yes, there was a benefit overall, but if you look at the two individual diseases, for ulcerative colitis, yes, the confidence intervals didn't cross one, cross zero, if you like. But for Crohn's disease, there was a trend, but there was no significant benefit there. So it appears that there might be certainly a significant signal there for UC, but it wasn't present for Crohn's disease. Why is that? Well, most things in Crohn's disease are harder to show. It's a more heterogeneous disease, and therefore sometimes it can be hard to show these things. But maybe the doses that are needed are higher, and maybe TDM has a role, but it's in selected patients, and maybe potentially not prospectively in this way, because doing this didn't lead to a significant difference. So I think these are interesting data. It's the first time there's been a prospective study that's shown that TDM, proactive TDM in IBD may be effective, but again, it wasn't able to land it for Crohn's disease. So I think there's still more data needed here. I'm not saying TDM shouldn't be used. All I'm saying is that you need to think carefully if you're going to do it proactively, because at the moment, based on this model, it doesn't appear to be associated with any better approach than standard dosing. All right, keep the questions coming. Don't be shy. All right, so this study is a study looking at HLA DQ105, and this is a haplotype which has been associated previously with higher rates of antibody formation and lower rates of and lower serum drug concentrations for anti-TNF alpha drugs. And overseas, this is often part of the celiac panel. And what they're suggesting is that patients who are going onto a biologic should have a celiac panel done, including looking for this haplotype. And if they have it, then these patients will be at a higher rate of having antibody formation, so 27% compared to 10%, as you can see here. And that might have you sort of watch out for those patients more. But certainly in New Zealand, I'm not aware that we have that haplotype available in our panel for celiac disease. And the question would be, if you measured that, would that stop you prescribing anti-TNF alpha drug? Well, we don't have any other options in New Zealand, and we don't have any data as to whether this is the same for other biologic drugs as well. So I think this is interesting. I'm not sure that in New Zealand it's ready for prime time, but it's another example of pharmacogenetics potentially aiding us with personalised medicine and selecting the right drug for the right patient. All right, so this is some data on ustekinumab TDM now, so trough levels for ustekinumab. So both these studies essentially show that there was a benefit in having higher levels of ustekinumab trough levels. They were associated with steroid-free deep remission and other outcomes as well. The study on the right is from the Mayo Clinic, where Vivek Tharial was, who's come back to us in Christchurch now. He was the second author on the study. And again, suggesting that TDM may be associated with a better outcome, but in fact, interestingly, no benefit here with combination therapy versus monotherapy, as you can see here in this study over here, and again in these studies as well. So when we get access to this drug, hopefully at some point in time, it would appear that combination therapy is less important. And I'll show you something that backs it up in a study in a little while as well. So that's really important, obviously, from a safety perspective, that maybe we could avoid combination therapy. All right, so this is another important study from DDW, and again, backs up the last study that I showed you as well. So this is the combo IBD study, and they're looking, it's a prospective cohort study, IBD patients on infliximab, vedolizumab, ustekinumab monotherapy with methotrexate or thiopurine for greater than 30 weeks were enrolled. And what they did was they're looking at the correlation between thiopurines, the 6 TGN levels, the use of methotrexate 12.5 milligrams weekly, and looking at trough concentrations of antibody and anti-drug antibodies, and also endoscopic outcomes. So on the left here, here's the drugs we have. So what you can see here is infliximab monotherapy in the green. The drug levels much lower. Infliximab and methotrexate, much higher drug levels. We know this, but again, a good study to back this up. What about 6 TGN concentration? Does it matter? Do you have to have patients on enough thiopurine to get a high concentration? Well, as you can see here, the concentration of infliximab increases over doses of and concentrations of 6 TGN, suggesting that you're likely to much higher concentration of infliximab in patients who are achieving higher dose, who are on higher doses of thiopurine, which end up with more therapeutic concentrations of 6 TGN. So I think we know this, but this is a nice study in a large cohort showing that this is the case. Now you compare that to vedolizumab or ustekinumab, it's a flat line. It doesn't matter whether you're giving monotherapy, combo therapy, methotrexate, thioguanine, thiopurine, doesn't matter. They all get the same drug concentrations, suggesting that combo therapy and vedolizumab and ustekinumab has no impact whatsoever on these on the final concentrations of these biologic drugs. Now, if we look at that now and try and convert that into clinical outcomes, so the outcomes here was steroid-free deep remission, so relatively challenging endpoint to get. Again, as you would expect, monotherapy here with infliximab under half, 71%. In combo therapy. So again, significant benefits there, backs up that importance that we know of combination therapy with infliximab. Although from the SPARE study earlier, if you are going to go monotherapy, make sure you continue with the anti-metabolite. Again, we can see here no difference whatsoever in the clinical outcomes for those taking vedolizumab or ustekinumab, regardless of whether you've got a immunomodulator on board or not. So again, really interesting, useful data that I can see there, and certainly something that I think would be useful. Again, keep the questions coming. Good to hear from you. All right, so I can't see any new questions in the chat at the moment, but please, as I say, let me know if you have any. So we'll move on now to treatment-related adverse events, safety, and vaccines. So Ozanimod, which is one of the mods, so they're the sphingosine receptor, phosphate 1 receptor agonists that keep those lymphocytes in the lymph nodes and stop them migrating to the gut. This drug in very early studies was highly suggestive that it was associated with cardiac conduction abnormalities. And we actually did this, the Trial study in Christchurch quite a few years ago. When we did the study, patients had to wear halters and all sorts of carry on to try and look for these things. So they went back over all of the data from all of the studies and looked to see, was there any change whatsoever in any of the cardiac abnormalities or cardiac things that were monitored in patients who were given the drug over the period of the study. And what you'll see here was that despite us being so worried about these side effects, there was a mean change in heart rate of 1 beat per minute at 52 weeks and 1.2 beats per minute at 24 months. So nothing clinically significant, no deaths, no hypertension, nothing to be worrying or concerning. So certainly no other, these events that we worried about didn't pan out in real life, which I think is great news. And certainly if we get access to these drugs, this will be helpful data. All right, so this is a slide that's created a lot of discussion over the last 4 or 5 meetings I've done around the country. So these are data from Korea. Now Korea is a bit like the Denmark of Asia, if you like. They've got fantastic nationwide population-based data. They can crunch it out really quickly and easily and give really nice summaries of real outcomes from their population. So what they wanted to do was to look at the risk of PJP, previously known as PCP, in their IBD patients. So they went to their databases and quickly had a look and found almost 40,000 IBD patients, very helpful. They then went and looked to see whether they'd been diagnosed with PJP, and they found 84 patients had been, giving an overall incidence of 40.43 cases per 1,000 patient years. And then they went and looked at the patient medication and other factors that were associated with an increased risk of getting PJP. The first thing you'll see here is that, not surprisingly, the older your age of diagnosis, which really probably equates also to the older age of the patient, the older age was associated with an increased risk of PJP in both Crohn's disease and ulcerative colitis. And we would all understand that getting older is a very immunosuppressing event, and we can see that occurring there. Male and female, no difference. What about COPD? Yes, in ulcerative colitis, COPD increase your risk dramatically as well, suggesting again that structural lung damage could potentially increase your risk of PJP as well. What about some of the drugs that we use? Well, certainly when you look in these standard drugs, or even anti-TNF alpha, just a small signal there with anti-TNF alpha, but in UC, no. But when you start combining these therapies together, so dual therapy, and UC in particular, and triple therapy, you can see quite dramatic increases in the risk of PJP. And with this in mind, they've suggested that prophylaxis for PJP should be considered in IBD patients in higher risk. Now, the discussion around the country has been, well, many people say, well, all my patients on triple therapy, which in New Zealand generally means an anti-TNF alpha drug, an anti-metabolite, and a steroid, I give them all prophylaxis with cotrimoxazole. Other people are saying, well, I had a patient once I gave cotrimoxazole to, and they died from pancytopenia. Doing that's not without risk. Should we be doing it for everyone? So I'm interested to hear what other people do and say in this space. Are people routinely using PJP prophylaxis in their patients? Do they all get it, or do they just pick out the patients who might be at greatest risk? Because if you look there, even those on dual therapy are at increased risk as well. And there are a lot of patients on combination therapy with a biologic and a thiopurine, for example. And are we really going to give all those patients PJP prophylaxis? I think not. So I suppose to me the key points from this study are thinking about those with triple therapy. How long are patients likely to be on it? Thinking about age is another risk factor. Thinking about structural lung disease as a risk factor as well, because we know that that's also going to drive this increased risk. So again, if you have any questions or comments on that, please let me know, but certainly there's been discussion around this slide this year. All right, not surprisingly, there was some stuff at DDW about COVID-19 this year, and that's useful because, of course, we're coming out through the initial worry that we had about COVID and IBD now, and starting to understand a bit more about vaccination response and how that might work. So this is a prospective, a number of studies on the slide, prospective multi-centre case control study of patients with IBD on a range of drugs without previous infection included in the analysis, looking at spike protein concentrations after the second dose of vaccine given 6 to 12 weeks after the first dose. What they found was that the spike protein antibodies were significantly lower if you took infliximab, combination therapy of infliximab and thiopurine, or tofacitinib compared to controls, and they didn't appear to see the same thing with those other drugs. So the signals appear to be mostly with, as I mentioned, combination therapy of infliximab and thiopurine, infliximab or tofacitinib. So these are the groups here: combination infliximab and thiopurine, or infliximab by itself. So in those patients are suggesting that patients should obviously have earlier boosters, and we should just be more aware that they may not have such a good vaccine response. What about this study? This is again looking at an Israeli study looking at patients getting 2 doses of vaccine 21 to 28 days apart, looking at neutralizing antibodies 6 months after the second dose. And again, what you can see here is that those on anti-TNF alpha drugs had lower levels of COVID-19 neutralizing antibodies that you can see here compared to non-anti-TNF alpha drugs. And again, if you look across a range of abstracts, the signals are mostly around attenuated responses seen in the anti-TNF alpha drugs and the combination. Not much data at all in the other areas, maybe a bit with steroids, but not much else. And again, this is sort of what we know. So thiopurines, anti-TNF alpha drugs, particularly in combination, are the groups that we should be getting increasing our vaccination schedules for. Good. All right. Moving on now to the next group of abstracts. This is disease-related outcomes, including recurrence after surgery, comorbidity, hospitalization, surgery, and disease assessment. All right, so this is a fascinating study, I think, and something I'd never really heard of before, and to maybe think as to whether it would change my practice. So this is data from the Cleveland Clinic. They have a large database of surgical patients, and what they've done is they've gone back to their patients with Crohn's disease who have had ileocolic resections, and they've identified those who have had intra-abdominal septic complications of those resections. So patients who have had an anastomotic leak, an abscess, something like that, and then looked subsequently to determine, do those patients have an increased risk of endoscopic postoperative disease recurrence? So this is down the track, do they have a worse disease course just because they've had an intra-abdominal septic complication from a previous resection, which in my mind wouldn't really make sense, but let's see what happened. So you can see here that multivariable logistic regression for known risk factors, and biologic prophylaxis, they try to control for all of that. And what you can see here is that in the red line, this was the group who did not have a intra-abdominal septic complication within 90 days, and in the green line, those who did, showing that there is statistically significant difference between those two groups, and as you can see there, and that also that's over time. And you can see here, if you look at it based on the timing of when it happened, that it appears that certainly if it happened within that 90-day period, appeared to be significantly more of an issue. So the question is, well, why should this be? Why would it be that patients who had abdominal sepsis have worse disease further down the track when it's sort of a complication of that? And it could be that it does reflect their disease, and maybe the anastomosis didn't work because they had more active disease, but they did try and control for a lot of those factors. The other question is, was there a delay in therapy? They may have all got biologic prophylaxis, but maybe those who had intra-abdominal sepsis had a delay in the commencement of that biologic therapy, because none of us would be particularly interested in restarting or continuing a biologic if someone has intra-abdominal sepsis? Or has it just been that those patients tend to have a more conservative treatment approach taken because of sepsis, which may mean that relapse is more likely? So again, interested in what you think about that as to whether that could be driving, what could be driving this difference that we see. But I suppose to me the take home would be these patients who have this abscess or have something post-operatively, often we're very much hands-off. And what I might be saying now is, well, hands off, but I need to get you back to clinic quickly. And as soon as we can treat you, we need to make sure that we do that, because you may be at actually increased risk of having recurrence subsequently. All right. So this is I put this in, I'm not quite sure why I put it in, but we do it every year. There's always a study that looks at, is there a difference between Rutgers I2a and I2b with regards to outcomes and post-op recurrence, and the answer is no. So you don't need to define them as I2a or B. You can just say I2 and leave it at that. Okay, so we look a lot at mucosal healing and inflammation as a potential marker of clinical outcomes sort of out into the future, but we don't often think about transmural remission and whether that's associated with better outcomes. It sort of makes sense, doesn't it? That if you can heal all the way through the bowel, that would lead to a better outcome than if you just had endoscopic remission. So this group did this over a 5-year period, a multi-center study, using MR enterography and colonoscopy if they were done together within 6 months. So they had 333 patients, and what they did is they looked at the risk of steroids, hospitalization, and surgery in those who had transmural remission, endoscopic remission, or no remission. And what you can see here is that for transmural remission, you were much less likely to require steroids than if you were in no remission at all. And there was a trend over endoscopic remission. There was a much lower risk of hospitalization, as you can see here, and those with transmural remission compared to those with endoscopic or no remission, and a much lower risk of surgery as well. And again, these things sort of make sense, because if you've got transmural disease, then you're likely to end up in hospital, and you may end up with a fistula or a stricture that needs treating. And I suppose the question is, should this be a target? Should we be treating patients to try and achieve transmural remission? Well, this study does not answer that question, but I think what it says is that if we do have data, if we do have scans on patients that show transmural remission, we can tell them that, you know, they have got a very, very good prognosis, and that maybe that could make us think about optimizing their therapy or reducing their therapy, as you've seen with the SPARE study, for example. So I think these data are useful, not as a target, but as something that might help guide us as to what we do with the cessation of therapy. All right, so you'll all be aware that intestinal ultrasound is playing an increasing role in inflammatory bowel disease, but it's also had a role in ulcerative colitis, and there are 2 studies from DDW presented here, including one from Flores de Vood, who was a visiting Dutch student we had in Christchurch a few years ago, so it's nice to see him getting his data presented at DDW. And what it showed here is that certainly you can use bowel wall thickness to predict patients who are likely to respond to biologics in particular. And it certainly can be used in ulcerative colitis as a marker of response to therapy. But equally, one of the issues with this is that the disease is often in the rectum, and you don't get great views of the rectum with transabdominal intestinal ultrasound. So I think it has a role to play, but maybe less so of a role than it may have to play in Crohn's disease. All right, so the good news about DDW this year is that actually we can all go home and retire now if you look after IBD, because artificial intelligence is going to take over the world, as you know, but it's also going to take over IBD. Here are 3 studies that show this with regards to outcomes of using AI across 3 different aspects of IBD care. And the third one in particular is really interesting, but I'll go through them sequentially. So the first one is looking at how good is AI using image processing and machine learning algorithms compared to experienced histopathologists. So there's manual and AI automated measurements of the NATSI index, which is an index for severity of ulcerative colitis, and they looked at how good it was, and it was very good compared to experienced histopathologists. So we can just send all our histopathologists home now, because we'll get AI to read the slides for us. That's fine, but what about our radiologists? What are they like compared to AI? Well, again, we can teach machine learning methods to the computers, compare that with IBD experienced radiologists, and again get very good outcomes. And if you look at cumulative ileal disease assessed by various measures and patients undergoing surgery in 3 years, we can see that AI is very good at doing that as well. So again, as good or better than experienced radiologists at picking outcomes of disease. And finally, what about endoscopy? So here we got computer vision measurement of disease severity distribution outperforms traditional endoscopy scoring for detecting therapeutic response in a trial of ustekinumab. So what they did is they went back over the centrally read endoscopies that were recorded, and used AI to teach the computer what was going on, and they then got the computer to reread the whole lot. And what they found is that actually the computer did a better job of detecting endoscopic healing than the central readers did. And if they used the computers and AI to look at this, they could have reduced the sample size in the study by 40%. Imagine how much money that would have saved in doing the study and how much quicker the drug would have come to market. So I'm not saying that the computers are taking over the world, or maybe they are, but these are some quite hard endpoints now that we're seeing where AI can play a role in potentially improving measurement of IBD severity using histology, endoscopy, and radiology. So I think fascinating now that we're seeing this coming out in this way. All right, so moving on now to quality of life, psychosocial implications, and quality of care. All right, so in the States, they're doing a study which is called the Confide study, which is an online quantitative cross-sectional survey of healthcare providers and their patients to see patients confiding in their healthcare practitioners, or do we really know what's going on with our patients? And this is one of the first outcomes from the study. There's another one coming up in a few slides' time. So 200 patients and providers in the US. And they're looking at symptoms which were the most important, or the top 3 self-reported symptoms suffered by patients with UC receiving advanced therapy. And what you can see here was that bowel urgency was the one that was underrepresented or underestimated, particularly in this group, and bowel frequency as well, bowel urgency. And certainly a lot of people with moderate severe UC on advanced therapies still had bowel urgency that was underreported by their practitioner compared to themselves. And again, they're suggesting there's a communication gap here between patients and healthcare providers. I mean, certainly from my point of view, bowel urgency is probably the most disruptive symptom that patient have, because the end point of bowel urgency is incontinence, and patients really, really don't like that. It's a horrible symptom. So to me, it's a symptom I always ask about very specifically, but I suppose the study really backs it up to say that we need to remember to ask about it. All right, so we know about ileal pouch anal anastomosis and the effect that pelvic surgery has on female fertility and also sexual dysfunction. Well, the study looked at male sexual dysfunction using the Explorers database from Cleveland. So this is an enormous database looking at a whole range of outcomes that have been captured. What they're looking there is sexual dysfunction defined by erectile dysfunction, impotence or ejaculatory disorder, and prescription of a phosphodiesterase 5 inhibitor. So you needed both of those things to have it. So it's a reasonably strict definition. And they looked at the potential risk factors for that. So with these large databases, they just pulled out 41,000 patients with a pouch, unbelievable numbers. And they controlled for all sorts of risk factors, and even after controlling for those, pouches were independently associated with the development of male sexual dysfunction. But if you add on top of those cardiometabolic risk factors and depression and age, you get more and more risk factors occurring as well. So all of those things need to be considered, and we need to ask our patients about male sexual dysfunction so that they can be managed. So staying on the theme of sex, we're going back to the Confide study to look at patients with moderate to severe ulcerative colitis in the US. What they found here, looking at these patients with ulcerative colitis, that over 3/4 of female and over half of male patients report avoiding or decreasing sexual activity due to their ulcerative colitis, mostly due to bowel urgency, fear of urgency-related accidents, and decreased desire. And again, this is getting back to that urgency story, isn't it? And the importance of if we can improve urgency, that they may improve other aspects of patients' life, including sexual health. So I think important to appreciate the effects of that, and also important to remember that that bowel urgency and being a major driver of that. All right, so we've got to the end of everything as it stands at the moment. So really happy to take more questions. But before I do that, I'm just going to go through sort of the top 3 take-home messages from DDW this year. So the first of these, I think, without any doubt, is the SPARE study. So although infliximab withdrawal was associated with a higher rate of relapse than immunomodulator withdrawal, almost all those patients achieve a rapid remission with infliximab retreatment, but remember, only if you continue the immunomodulator. So to me, really important study and something I'll use going forward. I'd love to use the EARNEST trial and REM switch studies going forward, but we don't have access to those drugs. But remember, the use of vedolizumab superior to placebo in a randomized control trial for patients with chronic pouchitis, and the REM switch study as well, switching from dose escalated IV to standard dose subcut gets lower relapse rates compared to those other ones as well. Thank you to Janssen for supporting us once again. Thank you for you all for attending. Good night and see you next year.